Today on The Reality Pill, we welcome an incredible surgeon, Dr. Randall Hayward. Dr. Haworth is my neighbor in Beverly Hills and one of the first people I looked up to when I moved into such a busy town. He's a very kind person, very welcoming doctor, and incredibly artistic in the way he speaks, eloquent, and really has an incredible understanding of surgery. Today, our focus will mainly be lips, as we are both lip specialists. We love to teach, and we love to teach our techniques. We have very different techniques between the two of us, which makes it such a wonderful topic to talk about. Dr. Haworth specializes in the upper lip lift and has been doing it a lot longer than I have. He's got various techniques that he uses and combines and has a very astute understanding of the upper lip and lower lip as well. So we'll be talking about my techniques, his techniques, and really help guide patients and doctors to avoid making mistakes and really help understand the anatomy of the lip better, as well as what procedures should and should not be performed on the lip. Everybody, this is Dr. Randall Hayward. He's I'd say one of the icons in the plastic surgery community in Beverly Hills, definitely from before I ever arrived, and one of the people I looked up to first, actually, when I got there, through a bunch of my friends who had said, "Hey, you got to check out this guy, Dr. Hayward. He's so good. He's amazing, and he does truly amazing face and body work." And the area where we overlap the most, that I really admire you for, is all the things that you've done with the lip, and you certainly do a lot of procedures on the lip that I'm not too familiar with, that I don't do very much. So I've got a lot of questions for you about your expertise, and I think this will be beneficial for people to watch who are going through looking for different types of lip surgery enhancement around the mouth, and then we can clearly chat about anything else you're advancing on recently. So the variety of surgeries that we have lip lift, and we have VY augmentation, the DAO, all this kind of stuff. The first thing I want to see is how do you really gauge who needs these surgeries? Like, what's your approach? Because I have a lot of doctors who ask me, like, "Oh, do you adhere to this rule, that guideline, that rule?" I stopped adhering to rules. But what was your process in getting to where you are now, and how you advise people?
Well, first of all, thanks a lot, Ben, for inviting me to, your illustrious page and and the podcast. And I'm pretty technically adept, but this was quite embarrassing because this is the first time, and of course, headphones aren't working, Bluetooth's not working. But anyway, how bad is the echo?
It's there. Let's see if I can get rid of it maybe on this side of things.
That's not bad.
It's still there.
1, 2, 3, 4. Well, I can work with it. How does the audience deal with it?
I think they said it's bad when I talk.
Okay.
All right. So
oh my God. Well, let's take it from there. Okay. How do I assess people? I think plastic surgery, like all forms of professional endeavors, is a language. Whether it's a pianist, plastic surgeon, actor, it's to the point where you have to learn the basics in medical school, general surgery training, or head and neck training, and then plastic surgical training. That's the alphabet. Then you start to learn paragraphs and how to create stories. And then it's to a point where you become fluent in the language, where you just don't think about it too much. I look at like numbers and measurements, etc. Though useful as the beginning of understanding the alphabet, understanding how to write prose, it gets to the point where I just consider those suggestions, and you become fluid and you just look at somebody. So when a patient comes to me and says they don't like their lips, they're not even quite sure of what they don't like about their lips. Now, some of them now, what you've popularized, Ben, and that's really beneficial to the plastic surgery community, is that you popularize the upper lip lift. Excuse me. And I've been doing that, a long, long time. And people understand that's almost like the missing key to facial rejuvenation. People always talk about the hands giving away your age, or your neck. I don't know how mine is, but
looking pretty good.
You have to give me a facelift then. I have to trust somebody. So I trust you. When are you going to do it for me? And and then you've got the lips to me, and I was writing about that in my textbook chapter, that the lips are really the missing key. And up till now, people were always talking about shape. Shape was always a secondary concern. They're always dealing with volume. And you have noticed that you started to act, what did you call it, about Juvederm. You said something like spreadoderm or something.
Moviderm, yeah.
Moviderm. Yeah. So, and it just turns into duck lips. So I equate lips to the breasts. There's a difference between breast augmentation and breast lifting.
Yeah, I agree. And when you look at the lip, I think from, what I love about your results is that you're not changing anybody's lip to somebody else's lip. You're taking what they have and you're enhancing it. You enhance it with either the upper lip lift, you enhance it with corner lifts, a little bit with VY augmentation, and then the lower lips as well. You kind of do either VYs or the DAO release that you do. Are there patients who come in who want like a different shape or somebody else's lip, and what do you tell them?
Well, they ask me, when I look at a lip, they say they don't like their upper lip. And I tell them, without abusing, because we as plastic surgeons have the power to abuse suggestion. You can sort of instill a lack of confidence or insecurity in a patient if they come in for a nose. And you say, how about your ears? But there's certain things that we talk about that are necessary because they synergistically improve the result. For example, a nose job. We always want to assess it with the chin. So it works synergistically to improve the result. So when somebody comes to me and they say they don't like their upper lip, I tell them that, remember, the lips are a pair. So we want to create interlabial harmony. I don't want somebody to just say, oh, you've got a great upper lip. Well, is my lower lip bad? You want to create interlabial harmony, which then in turn creates labial facial harmony. And then it just goes, ah. So when I look at that, some people have beautiful lower lips to begin with, or a great upper. So I look at that and I try to balance the upper and the lower. So I feel it behooves me as a responsible plastic surgeon to address the whole set of lips. And it's funny when in the morning, you know how they say with breasts, they say, would you like me to err on the bigger side or the smaller side? I ask the patients in the morning, hey, would you like me to err on the sexy side or the conservative side? So I even get grandmas, and they look like this. Sexy.
No, me too.
So I'd say, okay, it's a little bit more recovery, but, it's the results are worth it. You can get your Victoria's Secret model, Angelina Jolie, or it was really popularized by Brigitte Bardot, that sexy, insouciant, inviting, fertile indicator of sensuality we want to replicate.
Yeah, I look at it the same way, and I discuss that with the same way. For a lot of patients, there's the right or the wrong, but there's a range that you could do on some patients, and you tell them, I can make this a little, always natural, but I can go a little more on the exaggerated side of sexiness versus really, on the conservative side. So I put up a picture, if you can see it. That's a picture that you were talking about earlier. This is a good thing for doctors to know as a guideline. How would you describe it?
Okay, this is the sort of classic, this is the classic, what I consider anterior, posterior, in other words, full frontal view of the modern 2020 lips. So we have the upper lip and the lower lip. So we do get some interlabial harmony. They have to relate to each other. So what does the 1 and the 2 mean? Well, the 1 it's the vertical distance of visible vermilion show. And in relationship to the lower, that should be half the size. Some people even push the envelope and make it 1 to 3. Especially with the popularity of Instagram, where you get a different view of what's normal. So you have that, and then have you noticed, Ben, and this is your language too, that you see the upper teeth. And it used to be traditionally said in our textbooks, you want to get 1 to 2 millimeters in a woman. I think that's gone up to 3 to 4, even 5. Let's say if you look at Georgina Chapman, or her lips are like really pushing the envelope. And then if you notice here on the upper lip, it's a graceful arch, even Cupid's bow at the same height, and it's capped by a very soft but defined philtral column. Mm-hmm. And if you notice, I drew here that the white roll, where everybody injects to get this defined white roll, because the beautiful lip is not just a painting like lipstick, it has topography. So we want to preserve that topography. So the white roll isn't just a white, it's a roll. So it gives you some topography. And the white roll doesn't go all the way to the edge. It dissipates about 1/3 of the way down. So people try to create a white roll, but then they start to get that sort of too much injection of HA or whatever your favorite. You get that spam call. So you get that sort of duck-like look. And then if you go to the sides, you get a little hint of a curlicue on the upper, the corners of the lip, and you get that nice fullness in the middle third. So, and what's interesting is that the lower lip, when you look at a lip, you should look at the upper border right here, and the lower border, which is the actual intimate frame that serves as the framing of the backdrop of the teeth. So if you look at the lower lip, the ideal lower lip has an upper border framing the mouth that is straight, so you don't see the lower teeth. As we get older, our lower teeth start to show, and even though that's an indicator of aging.
Yeah, not very sexy when you start to see the lower kind of hanging there. And I try to advise patients when you're looking at direct lip lift, as you're talking about, if you can see kind of up here where I'm pointing on the lip, this portion where you have that white vermilion roll and the definition comes from, it's very harmful to go efface that with any kind of procedure, including like the direct lifts where they cut over there, unless there's a skin cancer or another reason. The place where it's okay, as you said, it tapers off on the corners, and you don't see that effect when you do corner lifts and things like that, right? So, I've done corner lifts for a while, I don't see effacement there.
Yeah, that's a very forgiving area, but all of that has to be precisely marked. I tell my patients that the marking in the morning for lip reshaping surgery takes me about half an hour with calipers and loop magnification. So it's very precise, and I've seen now with lip lifts becoming popular that I'm becoming a referral center for bad lip surgery from across the country, and I'm sure you're seeing a lot of that too, Ben. And I'm seeing some really fundamental mistakes, and I highlighted this also in this book chapter I wrote on complications, undesirable outcomes, there's a euphemism, in aesthetic plastic surgery. So I sort of detailed these sort of pitfalls, and they're difficult, even with a nose, if you've got a problem with your nose. With a good surgeon, you can really turn that into a gem. But with lips, when they go wrong, they become inexorably more complicated. And because the lips aren't there to just look good, they have to function.
Yeah, and I see the same problems. The issues with bad lip surgery is that a lot of the stuff done to the lips become irreversible. Some of the scarring, some of the nasal effacement, limitations in movement and the movement of the orbicularis, the musculature, it's irreversible. And that's the problem I have. So I have a long discussion with patients about, I can make your lip better, but I can't fix these certain things.
What do you do when you have a problem that I see so often? I call it nasal dystopia, where you have an unfurled nostril down in here.
So that usually happens after a tension lip lift combined with somebody who had rhinoplasty in the past or maxillofacial surgery, where they already have like a looser nasal base and then it spreads the nasal base wider and broadens it. What I try to do is I do internal stitches to try to anchor the nose back up to the piriform aperture, and usually it stays about 30%. So it ends up releasing after that, because there's not much you can do other than drilling it into place, which you can't really do without somebody who already has paralysis.
Yeah. By the way, they did say some echo here, and I do agree that it is hard because you have to almost overcorrect where they're in like this, and then it does relax. And I agree, maybe 30 to 40, if you're lucky, 50% improvement.
Yeah, something along that. It's always tough. So this photo, I think it's nice. I have a lot of echo, so I'll let you the inversion of the lip, the contour of the lip, and how lip lift can actually help all of this.
Yeah, I wish I had my headphones here, but bummer. But anyway, here what we see in a drawing that I did was that the side of the mouth is also very important. It's not just from the front, as we saw in those in the past drawing, but from the side. So we want that short distance from the nose to the white roll to the beginning of the lip. And it's got a sort of a provocative, in a way, concavity, ski slope, if you will, which we don't want in the nose. And then it goes upwards. And if you notice, compared to the lower lip, even though with the lip in the front view, we want the lower lip to be almost, let's say, twice as wide as the upper. From the side view, we want the upper lip to protrude in front of the lower by about 2 millimeters. If you don't get that, and this is where a problem when you get a VY, you have to assess the lateral view, because a VY will raise the lower lip to help hide the lower teeth. It will narrow the mouth, which is a very important subliminal indicator of youth. And also, it pouts out the middle half of the lower lip. So if you have a lip that's like this already, sort of a prognathic type of look, doing a lower VY will only make it bigger.
Right.
So you create that disparity. So it may look good from the front, but from the side, it's sort of an indicator of dim intellect.
So here's the photo's not coming in fully. I was trying to show an example of one that you had corrected. Let's see if I switch it. There you go. You can see it on a small view there. So what went wrong here on the prior surgery?
Well, this was a cleft lip palate deformity. So this a lawyer from Puerto Rico had many surgeries. So she presented to me with lips that she didn't like. She almost had the stigmata of, she felt that she was always going to be banished into invisibility, where she had to be ashamed of her lips and her nose. So when I looked at her, what I saw was an effaced vermilion border, which is a great example, Ben, of a loss of the natural topography of the white roll. And that was necessary, unfortunately, in this case, not cancer, but to reconstruct the cleft lip, where there's an incision here. And also she had a nose job, many, and that's not surprising that she would still have residual deformity because, as you know, they are hard cases to do, and they require many planned surgeries. So in her case, you can see from the side, I did her nose revision, and I did an upper lip lift and a lower VY, okay? And I highlighted the vermilion border because I wanted to do everything I can to make sure that from the side view that the upper lip protrudes in front of the lower. Because if you see her side view preoperatively, it's almost as if her lower lip is even or slightly prognathic.
Yeah, I see that.
Compared to her lower. So I have to be very careful with a VY in that case. So I have to overemphasize it. So what else did I do? If you notice, I reconstructed her filtral column on her on her right side because it was effaced. And that could be done partially by imbricating and overlapping if you open the scar, the muscle. But then I had to augment it with really, really superficial injections of a permanent filler of Belafil. And I also did Aquamid. And I almost am dealing with it, considering the filler as a tissue expander. So I'm putting it in, expanding it, very superficial, and then letting it go down, and then they come back like every 6 to 8 weeks, and then you build that contour. And I consider the filtral column not as columns, but they are sand dunes. So you have a sharper edge medially bordering that filtral dimple, and then it blends in a very graceful slope onto the side corners of the mouth.
And I think it's a very important thing to restore to make someone look more natural, as though they don't have a hair lip or a flat lip, but it's also one of the most difficult. So that's very impressive that you're able to restore it like that.
Thank you. I mean, it wasn't just a 1-2 punch that I tell my patients too. With something like this, it's going to be a 1 to 2 year process.
Yeah, so another thing I was curious about was the DAO release. So this is something that I've told patients before who have asked about it. I said there are very few people who I would ever say can safely and predictably do this. And I've mentioned your name for this before because I've seen it. And I've seen it in person in your patients too. They look great when you do it. Yet when I've seen other doctors do it, they end up with depressions or asymmetries. So what's your advice to patients when looking at DAO? What are the other options? And then, because if I tell anybody to do it, it's always to you actually for DAO.
Well, thank you. There are 3 types of corner lip lifts I do. There's the DAO, depressor angulioris, and just for our viewers that are unaware of what that Latin term means, it's the name of a muscle that emanates from the corner of the mouth and goes towards the jawline, and it gives you the sad look. Okay, so just like with Botox, it's a tug of war. We weaken the DAO, but in this case, we divide it, or I divide it, so that there's less pull down, and so that the upper elevators of the lips take over. So it's a tug of war. So that is done with an incision inside the mouth, and you divide the DAO. There are a few little vessels there that can be quite nasty if you damage them, the facial artery, etc. But it's important when you divide the muscle, just like when you're getting too aggressive with getting rid of the corrugators for a brow lift, you can be left with depressions. So I will oftentimes put fat in there, or I attenuate and thin out the muscle. The other thing, too, is that I don't do them as much as I used to, because, as I mentioned, there are 3 types of corner lip lifts, and they all bring different things to the table. And the DAO release is just simply a downward cant of the corner of the mouth. So if they do not have a flanking marionette fold like this, you see that there?
Mm-hmm. Yep.
A facelift, a lot of people will not correct that. I've got loose skin, so but you can sort of see here. So most of my patients have that. So a traditional corner lip lift not only elevates the corner of the mouth, but it also, the way it's designed, tackles that marionette fold that a facelift can't really deal with unless you pull so tight like Joan Rivers. You know, look, I have nothing, Mom. So that's that's what I do. The DAO, it's a good predictor by putting Botox in there or some other neuromodulator into that area, and it's a good predictor. The effects are very subtle, and the advantage why patients like them, there's a natural appeal because the incisions are inside the mouth.
Yeah, so these results that I'm showing, they're very difficult to achieve. Patients think that because the procedure is available or that it's described that any doctor can do it, these, personally, they're very difficult for me to achieve these kind of things. So what problems have you seen from revisions of other work that's gone on for corner lips or DAO release, anything in the corner of the mouth?
Well, DAO, I think the biggest... I would say the biggest complication that I see are depressions or an ineffective result. What I see with a corner lip lifts, the biggest issue when you're dealing with that is the cut on the side. And most of the time that heals very well, and I have tried, and I constantly try to evolve, trying to improve. I would say 5% of people need a scar revision on the side, and I laser the incisions before the patients wake up. I can't claim ownership of that concept. I came from the dermatology world. So you literally, in an unorthodox fashion, do a light CO2 laser on the incision. Mm-hmm. And then I make sure that I do all the usual plastic surgical technical things to make that scar very, very as flat as possible. It's more like there's either a bulge there or a invaginated look. But most of the time that works very, very well. Can always fix that if there is an issue. I know that there are a number of surgeons that in their good faith spirit to do good is that they say, oh, well, instead of making the incision on the outside, and this is more for you and me discussing this, instead of the incision going on the outside, they wrap it around the lower lip. So in other words, they're taking away that dog ear and sort of redraping it on the lower. Okay, and I know that Dr. Flowers was discussing, I think he wrote about it in the Valentine corner lip lift. I've done those before. I noticed, hey, look, it's so clever, but what's happened, and again, I wrote about this in that book chapter, is that they start to have this, after the swelling goes down, they have a weird fold that doesn't start here, it starts down here. Mm-hmm. And I was thinking, what the hell is that? And I had that in about 2 patients, and I realized what it is that you're wrapping the marionette fold, which starts at the corner of the mouth, you're wrapping it on the lower lip. And so they get this fold starting, the marionette fold starts in the lower corner of their lip. The corner of their lower lip, which is bizarre. And a lot of lip reshaping surgery is unraveling what the problems are. It's, as the Chinese said, 80% of the problem is defining it, 20% is solving it.
Right. Right. And it certainly is with this stuff, right? I've seen a couple of those myself. They're very difficult to treat. You really have to be very imaginative, I think, when you're looking at it and envision the outcome a million different ways.
Yeah.
And I'm just going to show a couple of examples of your work here. We've got patients of different ages throughout this. So the question I have is, do you think that the age of patients doing this stuff has changed? And is age really a determining factor for facelifts or lip lifts anymore, if you can do it naturally?
People ask me that all the time, and I tell them one thing. I operate on a problem, not on an age. So if a kid, for example, has a rare form of kidney cancer that only 50-year-olds and above have, I'm not going to deny them the kidney treatments. It's like, hey, listen, you got the problem. So the patients come to me, and I'm there to do the best job I can. But a good patient's an educated patient. My lip consults take a lot longer than, believe it or not, a breast augmentation consult or a rhinoplasty consult. Lips have got a very, it's not just the look and the function, but it's also got a psychological, psychosexual aspect that literally goes back to Freud. And if you have a really small problem on the lip that even us as plastic surgeons say, hey, that's nothing. Your net effect is that you're a wow when you walk through the door. But they perseverate on one little corner and they think it's a disaster. Whereas they are coming in and they've got a real problem with a crooked nose from 2 previous rhinoplasties, and they're not bothered by that. And it's because it stems from the fact that there is a subliminal connection between youth and sensuality in the lips, for obvious reasons and also for psychological reasons. You know, as they say, men's noses, some of the hardest patients to deal with are revision male rhinoplasties. Have you found that, Ben?
Yeah, definitely with the skin, and there's a fairly high rate of dysmorphia as well sometimes in the patient. And actually, I was going to ask you, I've quoted you a couple times when I try to explain to my patients. You told me a very smart thing once, which was when we're operating on people, we're temporarily making them sick to make them better. Or what was it that you said?
Yeah. I can't take credit for that. I think it was Harvey Zaram, in so many words. I'm paraphrasing it. But we have a huge responsibility as a plastic surgeon. We're their captain. We have to take them from to the other side of Mount Everest. So we're under their Sherpa. We have to take responsibility because in order to make a patient look better, we have to temporarily make them sick, unwell, in order to make them look better. So it's not just they're going into the usual, those cliches, or it's not going to a hairdresser or anything like that. But it's people don't realize that it's a tough job.
It's heavy business. So the question we have that everybody's asking, we'll over some questions now, is about IV sedation versus general anesthesia. What's your take on for lip surgery? I do general anesthesia, or I would say deeper sedation, for upper lip lifts, just because when I'm cutting out the skin, there is the superficial layer of the orbicularis oris muscle. That is the circular sphincteric muscle around the lip that does this. And so I sew the deep dermal superficial muscle interface to the bone, to the lining of the bone, the periosteum, and it's bloody. And obviously when patients are awake, I have to think of making them comfortable. That's an added moving part to what I have to do. And also it becomes bloodier because when a patient is uncomfortable, their blood pressure rises, their pulse rises. I want to make them comfortable because the point is I'm trying to give them a good result. But I do local anesthesia. When a patient comes and they just want a corner lip lift or a medialized corner lip lift or traditional, what have you, or VY surgeries, I do them under local because those can be just done in the clinic. Yeah. So either way can be done. Especially
I know you do it under local, but it's whatever you feel more comfortable with. I think the surgeon has to feel comfortable and confident in what they do.
Yeah, and you're also, I think the procedures are doing a little more tuning of the shape of the lip than I am. So you have more than just one procedure kind of going on. And increased time if I had a little bit of, a little touch here, a little touch there. I prefer them under sedation at that point because you're doing multiple things that get uncomfortable, and then that can alter the way you're doing your surgery.
Yep. Sometimes like with upper, when you're doing a lip reduction after they've had silicone injected or article in the past, Those are absolute nightmares. Bloody, and yeah, they can, and they dehiss often. They open up the incision. But what it is that for the audience, if they've got a full lip and you have to reduce it, plus they also have irregularities, that's the worst part. You have to make the incision on the inside of the mouth, and it can be quite bloody. And what it is that I equate it to operating, on a jellyfish, a moving jellyfish, because here it is, you have to move it up and down and trying to get that symmetry, and it's hard.
Yeah, so big question I have. I've seen a lot of doctors around the world advertise that they can remove silicone injections from the lips. And you are one of the people I would say is, a master of lip surgery with a ton of experience.
Oh, thank you.
How would you advise patients who come to you asking you, can I get silicone removed from my lips? Not implants, injections.
Number one, I tell them that it's not going to be, well, it depends. If they've just got a even, pillowy fullness, it's a lot easier to deal with. And I will tell them, listen, this silicone has infiltrated your muscle. It sort of grows. So the only way to really remove all the silicone is to cut your lips out.
I said the same thing, same exact thing.
Yeah. So, yeah, that's possible. But I don't think you want that. You'll get dry mouth. Can't speak well. But all black humor aside, I tell them I can improve the look. And you always have to overcorrect it with silicone, because remaining silicone has a tendency to come back a little bit. It's that zombie. You think it's dead and it still comes out. But the hard part is when you're having full lips and they're irregular with lumps and bumps. And I tell the patients, hey, I'm going to spend all the time. I aim for 100%, but you have to understand that you may just get 70%, 60%. And if you can't tolerate that, don't do the surgery. And sometimes this will take 2 to 3 go-rounds to get it close, to get them an 85% result. If 100%, we aim for 100, but it becomes hard. And you just have to make a judicious call, because with silicone too, you're cutting out some muscle.
Yeah, so I explain it to patients where we're treating the problems around the silicone, we're reducing the problems around the silicone. The silicone is a part of you now.
That's a good way of looking at it.
It's a part of you, and it's unfortunately a part of you forever. And if a doctor says they can get rid of it, either they don't understand it or they don't know how to explain it to you properly. Yeah. And they maybe just explain it wrong. They're reducing the issues, the hypertrophy, the problems, but the only way to get rid of it is to get rid of a part of you now. So, which is the same thing of like cutting out the whole lip. So I've had also a lot of patients coming in after rhinoplasties, and they say that their lip lengthened after the rhinoplasty, and the surgeon says, that's impossible. I didn't touch your lip. I differ on the opinion doing rhinoplasty and lip lifts. I say it's very possible. What do you think of this patient here that has a question about a columnar strut?
There are 2 reasons I think that the lip can appear longer, and one real reason. Number one, if they divide the nasalis, if they start with a sort of a rabbit look and they divide the nasalis in a good faith attempt to improve that excess upper tooth show. So that can drop, and it's unpredictable. And then the other thing too is if they have a really droopy nose, I ask them, the long upper lip is hiding in there. Mm-hmm. So when you elevate it, they think that the lip is longer, whereas in fact it was always there. And I think of it like a tree. The tree needs trimming. You get the tree trimmed and suddenly the light is hitting the grass and your lawn looks bigger. Okay. And so that is, for me, one of the things that I explain to them. And the other thing too is that when you're doing, let's say, columellar struts, etc., and you're going and putting it near the anterior nasal spine, you are creating some disruption, and they will definitely have 2 to 6 weeks of a long upper lip that looks longer than it is. How about you?
Yeah, I've seen that, exactly that, and I also see with any form of deprojection, so a transfixion incision or anything, let's say your nose is here, and you don't change the rotation, you just deproject it, you see the lip drops. So there's a sliding mechanism back and forth that drops the lip. And the other is the columellar strut. Naturally, the posterior portion of the medial wrap around the septum. Sometimes with a big columellar strut or a long one, you can actually push it in front of the septum. And again, that pushes it this way and pushes the lip down slightly. And their lip gets stuck when they smile, and that little crease that people form gets a little bit more exaggerated.
Yeah, I noticed you were talking about that at your oral facial club, if I'm not mistaken, how you were talking about that crease. Yeah, that's a good point, what you're bringing up.
Yeah, so for patients who have had a columellar strut, it's a great thing to have during the rhinoplasty, and you need it for the rhinoplasty. Sometimes it can affect your smile a bit, and if it does, then you just get a lip lift. If it's a big columellar strut or it's excessive, I'd actually have to trim them where they came in front of the nasal spine because they couldn't smile. Have you seen that? Like I had a long one before.
Oh, can you repeat that question?
For people who have had a columellar strut that's excessively long going in front of the nasal spine.
Oh, yes, you've had to go in and trim that, exactly.
Yeah.
And then also with upper lip lifts too, I've noticed when you have your columella as it meets the upper lip, you can have a very sharp angle. Mm-hmm. And so people talk about the upper lip and just shortening it, but we have the ability to round that so it's more natural into the base of the columella. So those are really subtle things that we have control over. And the strut, as you said yourself, they all interplay.
Yeah, I agree. And are you able to do a rhinoplasty and a lip lift at the same time?
Yes. It's a revision rhinoplasty is a different thing. You have to. It's a choreography. So if they've had a previous rhinoplasty and it's open and they've had a transfixion incision here, you don't want to. Obviously, you want to share the same incision by making the incision at the base of the columella, as you can do with a virgin rhinoplasty. But when they've had a transfixion, a transcolumellar incision or scar that's pre-existing, I don't start there. They have to have a separate scar. Otherwise, you could have a lot of skin problems, or that skin could die between that intervening skin between the upper lip lift incision and the previous pre-existing incision across the base of the columella higher up.
Yeah. So I always advise surgeons who are doing it two things. One is if you haven't done a lot of these, make your incision how you would for the lip, make it how you would for the nose. And then I would be cautious doing too much alarplasty at the same time. Because the bad scars I've seen are big alarplasties at the same time as the lip lift, they end up facing that little area over there.
That's true. And in a way, it's also harder to plan it. Because when you're doing your alar cinching, your rear excisions and you're narrowing it, obviously it changes your design of the upper lip lift, how much skin you take out.
And how long do you give between someone else's rhinoplasty and your lip lift, or your lip lift and someone else's rhinoplasty?
I generally do about three months.
Exactly what I said. Yeah. Same thing. 3 months and it settles nicely, and then you can be more predictable.
Yes.
So we've got a lot of questions for you. Well, a couple about how good looking you are and your dimples. You've got some compliments.
It's funny. Thank you guys, but that's not what I'm here for.
So there's laughing or stretching out the skin 3 weeks post-op damage or scar. How do you advise patients on facial movements?
Well, the problem is, not a problem, but part of the natural healing involved with my type of upper lip lift, what I call the OOS, which is orbicularis oris suspension, we've talked about that, is that there is stiffness. So I think it's an extremely beneficial surgery, but the one trade-off is stiffness that can go for about 3, even as far as 6 months. They'll look good, they'll smile, everything like that, way before then. But they'll always be cognizant because of the stiffness till about that point. And that's because whenever you operate on something that moves like hundreds of thousands of times a day, like the lips or the hands, every time you move, you're going to be reminded of the stiffness. So how does that parlay into the question? Right after surgery, they're going to be limited on how much they smile. They'll probably get their full denture smile after around 4 to 6 weeks, okay, like this. So they are going to be prevented. It's the surgery itself protects the scarring, if you understand what I'm saying. Whereas corner lip lifts, I've had 2 crazy stories, and one of them was a corner lip lift. And I tell patients now in my preoperative instructions, because of this story, to avoid amorous activity. I don't specifically get into the maneuvers.
I like details.
The details, but I try to do them euphemistically. And what happens, I remember this one chap I operated on, and he had a mustache, and I wondered why he'd want a corner lip lift, but who knows? So I did the surgery, came out fine, and took out his stitches in 5 to 7 days, can't remember exactly. And then about 2 days later, he comes and he says his incisions are totally open. And it's like, oh, yeah, right. And sure enough, he was the doctor. He as good as a doctor. They were wide open as if I didn't close them. And I said, how in the hell did you get that? And I was frustrated. He says, I was laughing. He's an older guy at the Dick Van Dyke Show. And I'm like, uh-huh. And then finally admitted to my female staff that he happened to have 2 people in his hotel room between the time I took out his incisions to the point where they opened up. So
it's good to be calm during the healing period for any surgery.
Yes.
I agree. All right, so we're nearing an hour now. Which means we're going to cut off, and I think we should do another one. I'm going to disconnect you from here so I can give you a little outro and talk about you for a second, just so it doesn't echo. There you go. So with Dr. Haworth, he really is incredible at doing the lip surgeries and does, has been doing it a lot longer than I have, and a lot of different things that I don't do and a lot of other doctors don't do. So I think we should do, I still have them over here on this computer, so I think we should do another one at some point, kind of tune a little more technical for doctors, and maybe do like a Q&A for surgeons, and hopefully the next orofacial club or the next face team or the next big congress, we can all, once they put it back together after this mess, we can go together, because last time you were missed over there. Everybody's kept asking, where's Dr. Haworth? Where's Dr. Haworth? They were really looking forward to seeing you there. And it was nice because it would have been me, you, and Dr. Spiegel, which would have been fantastic. Yeah, Dr. Spiegel's amazing.